Hello and welcome to the topic Chronic Lymphocytic Leukemia in the Haematology module. By the end of this session, you should be able to define Chronic Lymphocytic Leukemia or CLL, explain the pathophysiology and risk factors associated with CLL, outline the clinical manifestations of a patient with CLL, list the investigations that are carried out to diagnose, assess the severity, and prognosticate the disease, discuss the principles of management, discuss the complications, and finally discuss the prognosis of CLL. Let's get started. So chronic lymphocytic leukemia is an indolent B-cell lymphoma with lymphocytic leukocytosis, where monoclonal B lymphocytes are predominantly found in peripheral blood. It belongs to the group of low-grade non-Hodgkin's lymphoma and is the most common form of leukemia in adults. The median age at time of diagnosis is around 70 years. Let's take a look at the classification of CLL. The 2016 revised WHO classification of lymphoid neoplasm now classifies CLL and SLL, which is small lymphocytic lymphoma, as the same disease entity. The difference being CLL is when the malignancy affects B cells in the blood and bone marrow. When the same malignant B cells are affecting the lymph nodes and spleen, it's called SLL. Monoclonal B lymphocytosis precedes most, if not all, cases of CLL or SLL. It is defined as clonal B cell expansion, where B cell count is less than 5 times 10 to the power of 9 per liter, with no signs or symptoms of lymphoproliferative disease. B cell counts can be further divided into either low or high. So in low count, B cells are less than 0.5 times multiplied to 10 to the power of 9 cells per liter, and in high counts, it exceeds that figure but remains below 5 times 10 to the power of 9 per liter. Mutations in hematopoietic stem cells causes continuous activation of B cells, leading to mutated monoclonal B lymphocytosis. Further accumulation of genetic abnormalities and subsequent oncogenic mutations in the monoclonal B cells can lead to the development of CLL. These mutated B cells have impaired differentiation, stuck between an intermediate between pre-B and mature B cells. Morphologically, they resemble mature lymphocytes. Suppression of normal hematopoiesis presents as immunosuppression, thrombocytopenia, and anemia. Up to 2/3 of patients can develop hypogammaglobulinemia, and this puts them at an increased risk of infections and its complications. These patients are also more susceptible to autoimmune hemolytic anemia. The exact cause of CLL remains unclear, but is thought to be a result of accumulation of multiple genetic alterations affecting oncogenes and tumor suppressor genes, leading to increased cell survival and resistance to apoptosis. Risk factors include advanced age, as CLL is considered to be a disease of the elderly, environmental factors such as organic solvents, family history, and being a white male. These malignant lymphocytes initially accumulate in the bone marrow and infiltrate extramedullary organs such as the lymph nodes, spleen, and liver, to name the most common. This causes lymphadenopathy and hepatosplenomegaly. Most patients remain asymptomatic for a long time, which leads to late or incidental diagnosis. The majority of cases are diagnosed as an incidental finding on routine full blood count for an unrelated reason. Some clinical manifestations of CLL even include B symptoms, which are weight loss, fever, and night sweats. Painless lymphadenopathy, which is common, is seen in more than 50% of patients and more so in symptomatic patients. This can be localized with cervical and supraclavicular nodes or generalized. Hepato or hepatosplenomegaly is less common. Myelopoiesis suppression can cause granulocytosis, now leading to repeated infections, anemic symptoms, for example, pallor and dyspnea on exertion, and thrombocytopenia leading to coagulopathy. And last but not least, dermatological symptoms, which are rare but still can be present. Examples include leukemic cutis, chronic pruritus, and chronic urticaria. Moving on to investigations, lab studies routinely done are full blood count with differential. This reveals persistent, which is more than 3 months, lymphocytosis with high percentage of small mature lymphocytes, first suspected when absolute peripheral lymphocytosis, which is more than 5,000 cells per microliter. Findings that point towards suppression of normal myelopoiesis, as mentioned, you would expect to see granulocytopenia, anemia, and thrombocytopenia. Blood smears might reveal smudged cells or gum patch shadows that are ruptured mature lymphocytes appearing as artifacts. Beware of false positive, as mishandling of samples can also result in smudged cells. Flow cytometry is valuable, and that confirms a diagnosis of CLL with the detection of circulating clonal B lymphocytes expressing CD5, CD19, CD20, and CD23, with the absence of FMC7 staining and confirmed clonality. Patients with less than 5,000 lymphocytes per microliter, lymphadenopathy, without cytopenia more likely have small lymphocytic lymphoma, although this should be confirmed with a lymph node biopsy. Bone marrow aspirate is not necessary to confirm diagnosis but may be useful in investigating cytopenias of unknown origin, and this can, for example, during later stages of the disease, where there can be cytology and histology revealing more than 30% of small mature lymphocytes and reduced myeloid progenitor cells. In chronic lymphocytic leukemia, a smear would show predominantly lymphocytes, smudged cells such as arrow on the image on the right. Large atypical cells, cleaved cells, and prolymphocytes are often seen on the peripheral smear and may account for up to 55% of peripheral lymphocytes. A percentage more than this is more likely to be pointing to the diagnosis of B-cell prolymphocytic leukemia. In assessing severity or disease progression, a liver or spleen ultrasound may demonstrate organomegaly in patients with CLL. Considering obtaining serum quantitative immunoglobulin levels in patients who develop repeated infections, because monthly administration of intravenous immunoglobulin in patients with low levels of IVIG can benefit in reducing the frequency of infections. A bone marrow trophine biopsy may not be needed to make a diagnosis but is strongly recommended prior to initiating myelosuppressive therapies. A lymph node biopsy may be performed if peripheral blood smear does not yield diagnostic clues or to differentiate CLL from other diseases like Hodgkin's. Liver histology may demonstrate periportal lymphocyte infiltration and centrilobular necrosis in the case of leukemic infiltration. CT scans of the chest, abdomen, and pelvis are not routinely done in initial evaluation or follow-up, but may be used to identify retroperitoneal mediastinal or hilar adenopathy. Routine imaging is not recommended for initial staging. However, do be careful to not miss lesions such as obstructive uropathy or airway obstruction that is caused by lymph node compression on organs and internal structures. Next, chromosomal tests, although not necessary for diagnosis and staging, may help predict prognosis or clinical course. Additional diagnostic procedures or pre-treatment evaluation include fluorescent in situ hybridization for prognostic cytogenetics, and results should guide treatment strategies. Classical cytogenetic abnormalities found in CLL include the deletion of 13q14, 50% associated with better prognosis, deletion of 11q, that's 18% poor prognosis, and deletion of 17p, 7% poor prognosis. General considerations when it comes to staging: CLL is essentially shows different manifestations of the same disease, and SLL being mainly nodal, and CLL when the disease is confined to the blood and bone marrow, as mentioned earlier. The RAI staging system is mainly used in the US. It is primarily based on lymphocytic count, site of lymphatic tissue involvement, anemia, and platelet count. However, the Bennett staging system, mainly used in Europe, categorizes patients according to the number of lymph node groups involved and cytopenias. CLL is an indolent malignancy that is incurable with current treatments. Chemotherapy can achieve complete remission, but relapse is inevitable. Indications for immediate therapy include anemia or thrombocytopenia, symptomatic disease, rapidly progressing disease, and autoimmune hemolytic anemia or thrombocytopenia refractory to immunosuppressive therapy. In refractory or early recurrence in FIT, young patients consider allogenic stem cell transplant as it is the only curative approach. Remember, CLL is a low-grade malignancy. Therapy often do not and is unlikely to improve survival time. Medical therapy is palliative in intent. Palliative irradiation may be given to areas of lymphadenopathy or for liver or spleen involvement that does not respond to chemotherapy chemotherapy. Total body irradiation in small doses is sometimes done successfully for temporary relief of symptoms. Chemoimmunotherapy aims to induce durable remissions and prolong survival as well as relieve symptoms. Immunotherapies such as rituximab have been shown to improve survival and remission rates, particularly when it's used as an adjunct to chemotherapy. Targeted therapies such as ibrutinib is the most recent addition to therapy of CLL, and this is particularly useful in patients with poor prognosis, especially those with relapse or refractory disease. Supportive therapy is offered as needed. Now, let's take a look at the complications. Subsequent infections when patients are immunosuppressed remain the most common cause of death in CLL patients. Others include secondary malignancies, hyperviscosity syndrome, and autoimmune hemolytic anemia, both the warm and cold agglutinin type. The Richter transformation or Richter syndrome describes the transformation into a high-grade non-Hodgkin's lymphoma, usually into diffuse large B-cell lymphoma. In CLL, this occurs in approximately 2 to 10% of cases. An indication of transformation is rapidly progressing lymphadenopathy where the lymph node biopsy is required. Patients often present with new onset of B symptoms and have elevated LDH levels. Survival can range from 2 to 20 years, the median being 10. Without treatment, patients with RAI 0 to 2 may survive for 5 to 20 years. Advanced age are associated with poor survival rate. A genetic abnormality such as deletion of 17p23 associated with poor outcome because of a high risk of disease progression and poor response to chemotherapy. Beta-2 microglobulin levels are correlated with severity of disease. Blood lymphocytes doubling time, such as rapid doubling in association with high risk of disease progression. The CLL International Prognostic Index combines genetic, biochemistry, and clinical parameters into a prognostic model to stratify patients into 4 distinct risk groups ranging from low to very high risk. This will also affect the management protocols. Now, let's summarize. Chronic lymphocytic leukemia or CLL is an indolent but progressive accumulation of mature malignant B lymphocytes. Peripheral blood, bone marrow, spleen, liver, and lymph nodes are the most common affected sites. Signs and symptoms may be absent, but patients can present with manifestations of organ infiltration and bone marrow failure. Diagnosis is dependent on flow cytometry, immunophenotyping. Treatment often does not prolong survival and hence withheld until the patient is symptomatic. We have come to the end of this topic. Thank you.